Good morning, everybody.
Good morning.
I am Dr. Jeanette Scheid. I'm a child and adolescent psychiatrist. I'm on faculty at Michigan State University, where I get the pleasure of every once in a while seeing Dr. Abbasi. I do a variety of things, including some clinical work with children and adolescents in a couple of community settings, and for a fair amount of my time I spend doing non-clinical consulting to help bigger teams improve the health and mental health of kids in our child welfare in Michigan. And this morning, in the couple of minutes I have, I'm going to give kind of a whirlwind tour of attention deficit hyperactivity disorder and autism, probably as kind of exemplars of the fact that that we do have emerging and improving science helping us understand these disorders in terms of some of the factors related to causation, how to sort of distinguish them clinically, how to assess, how to treat. And so I'm just going to be giving sort of an overview of these two, but as you encounter children and families, some of these same principles in terms of assessment and treatment are going to be applicable broadly to mental health disorders. I'm presuming that this is the thing?
The green button.
Yeah, I did that. Is that right? All right. Oh, the green, not the arrow, but the little star.
No, the big green.
The big green button. Ah, there it is. Okay, and I get to go through this really fast, but for those of you, I mean, in when I usually give presentations, we are just like geared and like you don't even ask, you have to put these slides in. So I don't have any industry relationships, but our department was kind enough to help assist with my getting here. All right, I'm gonna.
Can you guys hear me if I don't stay at the microphone? Are we recording this?
Yes.
Oh, shoot.
Never mind. All right. I'm kind of a wandering speaker. So I'm gonna start with.
There's a mic right there. It might work. I don't know.
Yes. All right.
I am.
I'm a wandering speaker. All right, so I'm going to start with attention deficit disorder, and I wanted to just start with prevalence, which is a challenge sometimes because whenever somebody is trying to measure how often a disease occurs, a lot depends on how well it's defined and who's identifying it, etc. So there was a meta-analysis done which looked at the diagnosis of ADHD in the United States, in Europe, in Middle Eastern countries, and according to the different kind of diagnostic criteria that we have. And so as it turns out, their best estimate was somewhere around 7% prevalence in the population of kids. And there was initially there were some differences depending on which version of the Diagnostic and Statistical Manual that was used. And that was, and that remained even after they sort of looked at a number of different potential covariant factors. The diagnosis was a little bit lower in Europe compared to the US. Initially, the Middle East diagnoses, the studies were a little bit higher, and that difference kind of dropped away when looking at statistically at the other factors. And it was also higher, and this is not terribly surprising, when people just use checklists. And I'll ask you to hold that in your head because a little later on we're going to be talking about some of the challenges with differential diagnosis. So, all right. So the other thing is that it's true for ADHD. We'll be talking briefly about autism. That there are kind of layers of evidence saying that this is actually a real disorder. There are real differences. So there are real differences if you look comparatively at the brains of kids with a diagnosis of ADHD versus not. In ADHD, there is a tendency for there to be a reduced overall brain size. There's a difference in the white matter tracts that are sort of the conduits between the different sections of the brain. And there are changes in the frontal lobe area and in the deep central parts of the brain that kind of control arousal and attention to the outside world. We've also, several people have looked at using neuropsychological testing, and there are some differences between a level of alertness, which is not the kind of alertness that Dr. Abbasi was hoping that you would sustain in here, but more like the alertness and the capacity to maintain awareness of the world around you and then shift sets and pay attention, based on that attention. Executive functioning, which is, you know, on a good day, how many of us manage to get anything done, because we can plan ahead and we can think about things like how long is it going to take us to walk to the metro station and build that into our day planning. And then changes in reward and consequence, which is key in ADHD, that is very hard sometimes for individuals with that problem to pay attention to the things that are the most important, and then sort of make decisions accordingly. And then finally, we also know that there are some pharmacologic changes. There have been some studies looking at some of the brain chemistry. Now, all of this is to say, and whenever I put up biology slides on anything, we have so much to learn about the biology of the brain and brain behavior relationships, but some things do seem to be relatively stand out. This is driving me crazy. So we're going to shift to just the symptom criteria, and in the DSM-5, they have combined the hyperactivity and impulsivity kind of into one big cluster, and the inattention remained in its cluster. And so all of these things that I'm not going to read, that you can read in the DSM-5 if you're interested. But basically, it's folks who have a hard time paying attention, managing the details, sustaining attention, they put things off, they don't listen, and then sometimes they tend to be physically hyperactive, having a hard time sitting still when it's expected, and stopping and thinking before they do stuff. All right, I'm going to try not to take too long, but in my, when I'm working with patients, sometimes I will ask them if I were in a store at the same time you were in a store with your kid, would I hear you saying this? Leave that alone, put that down, don't touch that, leave that alone, leave that alone. And they're like, oh my goodness, have you been in the store with me? So the other thing is that, remember when I talked about the prevalence and how hard it is sometimes both on an individual level and then at a systems level to arrive at a diagnosis. So each of these things that I've listed for ADHD, there are other things that could cause these issues. So a person can be disorganized if they have if they are developing symptoms of a thought disorder like schizophrenia, if they are manic, if they are depressed, their attention span can be shorter. If the hyperactivity can come from anxiety or hypervigilance, blurting out or not waiting permission or being impulsive in that way can come from a variety of things, including anxiety and that watchfulness, and I'm going to intervene before something bad happens, or a person who has hypomania or mania. And so it really can be difficult to tell in a clinical arena what's going on with that, and that's why in a clinical sense it is so important, and anybody who's, knows parents, everybody has a right to expect that a clinician working with a child is going to approach this in a comprehensive manner. So they're going to get reports from multiple sources, from parents, from other caregivers, from teachers, from coaches, from anywhere where that kid spends a substantial amount of time. What is that youngster like in that setting? They can use some tools. We have some symptom checklist tools, and I've named just 2 of them here that again are a part of the piece, but not all of it. And then really important to look for the other things that could be causing what is a presenting symptom of not paying attention or really hyper. Just very important to do that. When it comes to treatment, we do have, and I think that the ADHD had been sort of the quintessential, you gotta treat it with medication disorder, that and perhaps schizophrenia. But especially in young children, there is an emerging evidence that in that 3 to 6-year-old age group especially, using some of these behavior management techniques that are sort of a lot more focused on the relationship between the parent and child, teaching the parent to sort of help that child learn executive control and emotion regulation and all of that kind of stuff is really important. Some of those kids will go on and need medications anyway, but in the very young age group, there's emerging evidence for using psychotherapy alone. And then there's just like a whole list of medications. I started with the FDA-approved medications, which are we used to call them the stimulants. Then the medications like clonidine and guanfacine, their extended release versions have FDA approval, and then Strattera or atomoxetine works with the norepinephrine reuptake system. And then sometimes clinicians will use alternate medications as well, although they do so with probably less strength of evidence. So, all right. And then what to expect over time. I think that a few decades ago, we used to think that kids just grew out of ADHD, and I think that that is not a belief that most people hold. There are some persistent problems with attention span, executive control, reward, mood, with substance use, and some of that can be helped with adequate treatment. So I'm going to shift over to autism in my last couple of minutes. So autism is something that has been increasingly happening, at least in the United States. A few years ago, the prevalence was like something in one in like closer to 100. In more recent years, it's 1 in 68 children. I don't think that we understand exactly all of the reasons for this. Some has to do with increased awareness. And sort of everybody thinking about the possibility that a youngster might have an autism spectrum disorder. It is a very complicated disorder, as are all mental health disorders. So there is some genetic risk. There is some, it runs in families. But there are also some other risks, like children of older parents are at higher risk. There is some evidence emerging that using vitamins with folic acid can actually decrease the risk. We also know that there are some brain changes, although we're still learning about that. And so, for example, some parts of the brain tend to be larger. It's thought that maybe there's some difficulties with how pruning happens or the anatomy of the brain develops over time. And then there are, especially in the connectivity of different parts of the brain, there seem to be some deficits. So these are the diagnostic symptoms. Basically, the idea is that youngsters with an autism spectrum disorder struggle with social relationships and interaction, and they struggle with being flexible and tolerating changes in routine, listening to other people's interests because they are so focused on their own. And they can also have some sensory difficulties. And although this isn't in there and it's not a diagnostic criteria, it is pretty common for kids with autism spectrum disorders to have difficulties with sleep. And I gotta tell you that from a family perspective, this is critical because people cannot survive without sleep. And so that is something that you might encounter when talking with people. So in terms of how to think about this from a differential diagnosis, I was talking with my co-panelists, and when somebody has clear-cut autism, it looks like autism, and so there's a little bit less in terms of concern about differential diagnosis when the symptoms are big enough. But it may be important, and this is where I'm less expert in this area, as to whether or not there may be any cultural or family characteristics, such as under what circumstances you make eye contact, that may impact the decision or the diagnosis, especially at the milder end. So that is something. So here too, across the board for mental health disorders, a comprehensive assessment is just critical. And it is something that I don't know that parents necessarily always know that they have a right to expect. It is critically important, and they have a right to expect that of their caregivers. So reports, again, from multiple sources in multiple places. There are a number of symptom tools that can be helpful in the United States. It is part of the requirements at 18 months and 30 to 36 months to use this modified checklist for autism in toddlers as a screening tool in primary care. And then using diagnostic tools along with that. Really important to look for cognitive functioning. One of my co-panelists is going to be talking about cognitive intellectual disabilities, but also to look at the possibility of coexisting problems and make sure that those aren't being left behind. The hallmark for treatment for autistic spectrum disorders is really behavioral treatment. So applied behavior analysis, social skills training, but also that broader family support. And then, depending on the individual who may have some other needs, making sure that treatment approach is individualized and comprehensive. There is no medication that is specific to autistic disorders, but people have used medications to curb aggression or agitation. And if somebody has a coexisting disorder, it is important to consider how to treat for that, although monitoring that is a kind of challenge. In terms of what to expect over time, with these interventions, individuals usually show some degree of improvement in daily life skills, in communication, in relatedness to others, and that will vary a lot depending on the person. There is the risk of other mental health problems that can occur, and so monitoring for these, which can be difficult sometimes under the circumstances where a youngster is not as capable of describing their internal experience. So assessing for anxiety and mood and psychosis can be very difficult. But ultimately, and I can speak for the United States in general and for Michigan where I have more experience, is that there certainly is the recognition that addressing the issues in individuals with autism is certainly a lifelong, even though it is a childhood onset disorder. So that is what I have for presentation. I have put in here some references, some are basic like the DSM, a couple of research articles, but also just a couple, and there are more, of web-based resources such as the Autism Speaks website and Scheid, which is for an ADHD. So with that, I will close.
Organizer of this conference, especially to Dr. Abasi, Dr. Megan, that they provide particularly me, my university, to share the different researches on this forum. Though it cannot be generalized here in the Muslim population living here in United States of America, but there's something which can be linked with the presentation which Dr. Mala presented on. Actually, my topic of PhD was effects of children with intellectual disability on family. And I discovered different topics from that area. Last year, I presented a paper that was mysticism, substance use, and mental health in Pakistan, and it was basically emerged from the same work. Now, the current topic of my presentation is superstitions and parents' interpretation of their children's intellectual disability. Superstition. This paper is basically the interpretation that how parents, families view intellectual disability, especially autism, in the cultural perspective, how they interpret it, how they link the causes of such disability with different things. As the birth of the child with intellectual disability carries very socioeconomic and emotional problem for the family. As ID is considered as a stigmatizing disability, therefore it is mostly concealed in Pakistan. As a result, the child reached to the age of 7 when it is recognized that this is some sort of disability a child reached to, because it is normally concealed, because so many stigma and things are basically associated with that thing. So that's normally that affect the early diagnosis of the child. As other worthy speakers, they shared that the accurate information in awareness about the causes, nature, types, and treatment of intellectual disability among children are necessary for their rehabilitation. Normally, parents may have little need to reflect on the understanding of disability until having a child. Owing to lack of awareness and stigmatizing nature of intellectual disability, parents normally go for different superstition in Pakistan. As superstitions are normally defined as an irrational and invalid belief about certain actions which emerge from the notion of good luck or bad luck. As far the concept of intellectual disability are concerned, you may be well aware, according to the American Association on Intellectual Disability, Intellectual and Developmental Disability, ID is a particular state of functioning that begins in childhood and characterized by limitation in both intelligence and adaptive skills. It was previously known as mental retardation, and still in Pakistan it is in official jargons, and the name of the institute still it is called as mental retardation because nobody knows about the intellectual disability or intellectually challenged child. It is still known as mental retardation there. As for the prevalence of intellectual disability is concerned, the prevalence of ID is increasing globally. In 1994, around 3% of the world population, that's 156 million, had some form of intellectual disability. In 2001, however, it rose to 15%, which means 85 million people have some form of intellectual disability. According to the one of the survey conducted by Autism Resource Center in Islamabad, I personally visit this institution for data collection purposes. According to the survey, there are currently 350,000 autistic children in Pakistan, which means 1 out of 66 children is autistic. As far Khyber Pakhtunkhwa is concerned, this research is basically carried out in Khyber Pakhtunkhwa, which is one of the 4 provinces of Pakistan adjacent to Afghanistan. And Khyber Pakhtunkhwa is somehow a bit unfortunate province, I think, because the war and terror and the problems occur. That's normally a frontline province in Pakistan. The people are really facing different type of mental health issue, but this is, and just because of that, this geographical features. As for this study is concerned, to study the prevalence of superstition among parents having children with intellectual disability, a qualitative study was designed to explore the causes of superstitions among ID and its effect on the detection and rehabilitation of children with ID in the target area. Information was gathered from different participants, especially from the parents and from the other caregivers. As it was a qualitative study, so out of 27 districts, 2 districts, District Peshawar and District Haripur was selected purposely, and the reason of the selection of these provinces was that there were 3 institutions where the enrollment ratio of children with different disability were high, so they were picked purposely. And 3 institutions, their name is Section for Mentally Retarded Children at Special Education Complex, Hyderabad. Hyderabad is one of the posh area in Peshawar, in Khyber Pakhtunkhwa. Center for Physically and Mentally Retarded Children is another in Peshawar, and Center for Physically and Mentally Retarded Children in Haripur. As parents and primary caregiver, where there were parents were not very well, so grandparents, maternal, paternal uncles, they were interviewed. And this was basically a total of 13 in-depth interviews were conducted, and 4 focus group discussions were conducted, and their lived experiences were captured. These were some of the findings. For instance, the ignorance on the part of the parent about the causes of intellectual disability. This study showed a significant relationship of superstition belief with the ignorance and lack of awareness among parents about the causes of intellectual disability. And yet, they have a very close relationship, and it was found in the study that when a child infected with such condition during birth, family frequently wanted to know whether the defect occurred in the mother or in the father. Moreover, family also associated such disability with possession of jinn, it's Urdu word is spirit, or some illness. For instance, a mother who shared her opinion about the occurrence of ID of her child during an individual interview, that after 40 days, the birth of my child, I took bath and visited a nearby village for attending a marriage ceremony. During an extreme cold weather, after attending the ceremony, when I was coming back at around 12 p.m., came across an area which is famous for gin, and this is in Pashto. The gin is normally called piriyan, gin or ghost. And soon after reaching home, my child get reddish. We kept him. We quickly kept the child with a warm clothes. Since then, he developed that thing. But when the same thing was then another psychotherapist when they shared the thing, they said that he was basically infected with some sort of fits, and that fits later on emerged as a cerebral palsy. But her first interpretation of the causes of that it is not because of that thing, it is because of that's superstition. As for the superstition about the causes and treatment of intellectual concern, most of the participant of the participant, they and majority of the parent, that what is actually the cause of this is they say that it is because of the bad nazar or evil eye of some of the jealous relative, and they basically relate it with bad eye. For instance, religious spiritual leader of the mosque or madaris were considered as the major source of healing in such cases. Moreover, shrine of saints, mazars, were also considered as the places of treatment and recovery for such disability. For instance, a grandmother who shared her experiences that when a doctor revealed that the child, the disability of the grandson, I immediately took him to holy places for manat, wish or pray to Allah through saint. Even I sent his child to a madrasa named as Banori, which is one of the prominent religious institutions there, for spelling holy word on his shirts. After some time, we contacted them. They shared that the child had recovered. However, his mother has to recite some verses from the Holy Quran 100 times after each prayer, and would spill upon him as they came to know through istikhara that the child is under the influence of Dev or some sort of spirit. So these were the religious scholars, and especially the mazar or the shrines, they are considered as one of the strongest institutions for recovery. Superstition as a source of psychotherapy and healing for affected, and this is what I call it. It is some sort of, though it's have some negative consequences, but it is basically one of the strongest source of informal psychotherapy for the parents, as the concept or awareness regarding the mental health is not that much there. There are very few institutions. There are in medicine, there are very few psychiatrists who are working, and there is no mass awareness regarding this thing. So superstition, what I personally found is that and that emotional setback, that's normally give them a very strong support in that crisis situation. That when they realize their approach to the shrine, they incline to the religion, the Holy Quran, the different things, and by that way, otherwise, if this thing was not as I said, the institutions are not that much strong, there is no that much awareness, so that may cause further psychosomatic disorder for them. The same traumatic feeling were expressed by a mother during individual interview in Peshawar. I cannot forget that moment when a doctor told me that the child have got disability. It was a shocking news for me. I went through depression for my days and even attempted suicide. She was basically a bit, even she was an educated mother, and she said that I went through that thing, and because of that thing, even I committed suicide, because she was from a very extended family, and that basically she take her daughter that why this thing happened, and it would be a source of taunting for me. Why this thing is happening to. So just because of that thing, because of the child disability, and because of that thing, she said that even I attempted a suicide. After affected mother shared her first reaction during an interview in Haripur in other term, when I came to know that my son had got disability, it was not less than a thunderstorm. I immediately took him to a nearby peer in Scheid, where he spelled holy words. Consequently, I felt relaxed as he assured that the child will be absolutely recovered. The function of superstition in such situation was also endorsed by an anthropologist, Rob Nicholson. Superstition can be a source of comfort during uneven social situation and help in controlling situation. For instance, eye jumping superstition is connected to loved one which is normally deep-rooted in people's thought. Such superstition can help mother to relax and reduce anxiety about the future of their children and provide psychological and emotional support to such families. There was a gender differences in this superstition belief. For instance, in this study it revealed that the mother were more superstitious as considered to the father. And this is just because that the literacy ratio in Pakistan is comparative. There is a discrepancy of gender ratio that there are 38%. The overall gender ratio of literacy in Pakistan is 38% for female. There is some, and 67% for the male. There's some corrections needed. So just because of this, sir.
So this isn't mental health literacy you're talking about. This is literacy.
Yeah. This difference is just because of that thing that that the literacy ratio among male is a bit higher. They are more aware. They have more exposure, and mother or female have less exposure. So it was one of the things that superstitious tendencies were more among the
So
among
there was
the
an inverse relationship between educational status
Yes.
and holding these superstitious beliefs.
Exactly. Similarly, economic status of parents and superstitions, that those parents who are well off, who have less tendency of superstitions, and those who are have very low socioeconomic background were more superstition. And there was economic reason for them, because they cannot afford medication. They were unable to afford to approach to any psychiatrist, anything. So this approaching to a shrine, approaching to a religious scholar was found as one of the even cheapest way to overcome their emotional problem. And so conclusion that there were misconception and myths about the causes and treatment of ID in the field area of the study. People considered it as a complex problem. And this thing, as we said, that though it's education play, awareness play a role, but as I was discussing with Dr. Sarwar, that still the superstitions or the cultural things are much more dominant in Pakistan when there are mental health issues, when there is a thing. And for instance, I was sharing my personal experience that when I was writing this paper, it was some sort of, I was an outsider. But when the same thing, happened with me, Allah blessed me with a son on, 7th November, and then we was quite okay. On the 1st January, the son was infected with bronchiolitis. Then when we take him to the hospital, he was there for 3-4 days. But then his condition was a bit, getting worse and worse. In final time, reached that he was infected with encephalitis. And encephalitis is one of the root causes of that thing. So during that condition, in my family, everybody was coming to me. So the same thing, when they say that, oh, the name of the child, his name was Ahmed. So Ahmed Shakeel, so the name of the child is, this is wrong thing. Why you, call him Ahmed? Because this is the feature of Almighty Allah. So I'm changing. So what should do it, Abdullah? Okay, you did a Aqiqah for the child. No, because of the time I'm slow. No, you just do it. Okay, I did it. The other things that you're under the influence of, this evil eye, your family. So what you do for that? Then a religious person came, they spill out something. But ultimately, unfortunately, my child, after hospitalizing, after 28 days, he passed away. And the thing which I personally, the things that though I went to capture all the experiences of the parents and those things, when I personally experienced that thing and realized that thing, that actually we are conducting researches, but there is no, institutional support, there is no awareness, there is so many institutions are there. So just because of that thing, that's caused a lot of, mental health disease. And personally, for me and my work, if we come out of that thing, though that thing just because of that other social support and the thing, but this thing, I personally got this motivation from all these things that this has to be taken. Though we normally say that the state would do this and that, but practically no. I take this initiative with some of the friends who are psychologists or psychiatrists. We are going to have some sort of platform which could disseminate this information, which could provide some sort of support to those parents who are suffering from such problem, so they could come, they could share their thing. And even one of another area of there is normally a problem that people are organizing look for donor there, but there is a very, in spite of these, some negative thing, there is a very strong resources, social capital there in Pakistan. That is the indigenous form of philanthropy in the form of charities that's staying, and still that is not being explored, that is not being institutionalized. For instance, we normally teach social work, but the theories which we are teaching there, the theories they're normally from the transplanted from the developed countries. There is a very strong sources in the form of zakat, and there are many other things which need institutionalization, and that's have a lot of resources. So we are now planning that we have to utilize those informal sources for it on self-help basis. We have to take some steps for who are coming for approaching to such family who are just because of these stigma and taunting. They normally, those children who are normally have, for instance, autistic children there. Autistic children are normally, they're associated with the different things that, okay, he will start speaking after some time, because the parents are not accepting that disability. And when a child reaches to the age of 7 or 8, for instance, I remember one of the Welsh family when they migrated from Khyber Pakhtunkhwa to Islamabad, which is the capital of Pakistan. They settled there and they started in this autism resource center. So the first response of that institution was that you are very, very late. If these children was diagnosed early, so there were certain therapies, there were certain things that they can overcome this problem. Though I personally visited them last month, so the children there is a very drastic improvement in their children, because when I personally visited even that institute located in Islamabad, they have very well, and that institute is running with those self-support system. They're not looking for any donor, and there are 3 mothers who belong to a widow family. They established this Autism Resource Center, and they are providing a very best services. But this was basically the response of those parents that this was the first response that you are late. If your child is in the age of 3 or 2 years, so early detection could enhance their rehabilitation. Thank you very much.